Good morning, everybody. I welcome you for the session, The Future of Combating Neglected Tropical Diseases, organized by the German Network Against Neglected Tropical Diseases. My name is Achim Hörauf. I'm chair for microbiology and parasitology at the University Bonn Medical Center, and together with my colleague Carsten Köhler from University Medicine Tübingen, we have the honor to chair this session, and I'm very happy that we seem to have met the interest of quite a lot of people. I also hope that we can be understood virtually by all those who have joined us via Zoom. Now, our topic fits almost too well to the general topic of this year's World Health Summit. How can we organize ourselves in a more fragmented world and keep the momentum that we had for global health? And this also applies very much to the neglected tropical disease field, because all over the place, funding has been cut, and we need to reorganize ourselves to make most out of it. For one thing, we can be proud, because if you take the World Health Organization's roadmap for NTDs, calling for 100 countries by 2030 to have eliminated at least one NTDs, we are well underway. We have 50 countries at half term, more than 50 countries, so we don't have to hide. We also have, in global health in general, achieved a lot of results that have even helped European and North American countries. As an example, a malaria adjuvant for the malaria vaccine, the RTS vaccine, has helped speed up the COVID vaccines quite a lot, so saving a lot of time and lives. And the figure for every dollar that is invested in global health, what comes in return is between 10 and some say even much more, like a lot more. So whatever, there is a good case for investment and for continuing engagement. Now, in facing the cuts and reorganizations, WHO recently has reorganized themselves, and we will have Maria Rebollo from WHO talking about these and other success stories. And we have NGOs that have to make more out of it by bringing together programs that can be combined. We will have Karutu from the End Fund talking about these achievements. And last but not least, the whole programs would not be possible without donations by pharma. We have Johannes Waltz from the Schistosoma Initiative talking about his reflections about the new situation. And industry can also make a difference, and together with the public sector in PDPs, in product development partnerships, really by new drugs make paradigm shifts. And we'll have Laurent Fraisse from DNDi elaborating about that. So I expect great talks and great discussions. So please, after the presentations, have questions, and we will try to take as many as possible in the 1.5 hours. With this, I hand over to Carsten.
Yeah, Achim, thank you very much for your introduction, and to all of you also a warm welcome from my side. When I was checking out this room yesterday, I thought it may be a little bit too small, and it is a little bit too small, but there's one spare place left in the first row, the quickest of you standing around, so please take the seat here in the first row, then you have the best perspective. It's a workshop, and therefore I'm very glad that we have 4 distinguished speakers, but we have 90 minutes. That does mean we have enough time also then to discuss with you your questions and maybe to find solutions how we can combat neglected tropical diseases. Okay, then Achim, we will start, not to lose any time, and you will introduce Maria, I guess.
Maria Rebollo Polo. She is at WHO and is the lead for the Global Onchocerciasis Elimination Program. So onchocerciasis is different to some other NTDs, is an elimination, not elimination as public health problem, but real elimination. And Maria, I came to know her even before she went to Brazzaville to be head of ESPN. But there I learned what can be done by digitalization of surveillance. And I think this really brought the 5 PC amenable diseases much to the forefront, because the digitalization allowed that all countries feed their data into a platform with much shorter turnover time. So this is what I remember as one of the achievements. And now with WHO, she is behind GON, the group for onchocerciasis elimination. And yeah, you will probably tell us also about restructuring and what you can take positively out of it. Please, the stage is yours. We
come here so that I can see you well.
And I think I have to get the presentation. Oh, there you go.
Very good. Well, thank you for choosing the right session to talk about neglected tropical diseases, despite all the competing interests. That is good prioritization. We like that. And I have slides that are very packed of information that I will not have the time to cover, but I wanted to bring it just in case for later you want to know more about it. So you will see some of the things I will not have the time to cover. So very briefly, I will talk to you about what is happening in WHO, how we are merging the malaria and the NTD programs, what has been the progress to date on the NTD world since the London Declaration and then since the roadmap was launched. What are the key barriers that we are facing right now that you are probably too aware of them, unfortunately, and what are the opportunities and enablers and some key recommendations. So the global NTD program started in WHO in 2005, and I think it made sense at the beginning to have it as a standalone program, because NTDs were not even recognized by countries, they didn't have the priority by the global community. Therefore, having a department completely focused on NTDs made a lot of sense. Diseases have been added slowly, and now we have more than 21 diseases and group of diseases, of which NOMA has been the last disease being added into the package of neglected tropical diseases. The London Declaration in 2012 marked a pivotal point with the launching as well of the NTD roadmap, and then the second NTD roadmap in 2020 towards 2030. And as you know, we have the different strategies, what we call the preventive chemotherapy, where we treat as mass drug administration to eliminate diseases, and that is schistosomiasis, lymphatic filariasis, LF, STH. We have individual case management diseases where you have to do individual testing and treating. We have vector control activities, veterinary public health, and WASH. And as you can see, many of these interventions really link very well with malaria, because malaria also have approaches that are important for preventive chemotherapy, individual case management, vector control. Therefore, we made the decision that nowadays it doesn't make sense to continue working in silos and actually have a more person-centered approach and community-centered approach where we can deliver these interventions in a much more integrated and comprehensive way at community level. So we decided to go ahead and merge the NTD and malaria department. And I know you cannot see all these details, but hopefully you can have access to the presentation later. We are going to have 3 main units: the prevention, diagnosis, treatment and care, the strategic information for impact, and the vector control and disease control initiatives. So all those units are going to be merged for malaria and NTDs, and we are going to have a joint database, a joint sharing with teams. And I think this is going to be great because we are going to try to think out of the box, learn from one another, and try to see how we can deliver better at community level in a much more comprehensive way, like working really with the health system and delivering things that make sense for the communities rather than working in vertical silos. And as I said, I will leave you the slides later for reading the names and the details. So what is the progress made to date? Well, I think the NTD world has made huge progress. Up to 2024, 1.5 billion treatments were delivered just in 1 year for NTDs. If you see the decrease of number of people no longer requiring interventions from 2010, where the first roadmap started, up to now, we already have 700 million people no longer requiring treatment because the target of elimination or elimination as a public health problem or control has already been reached. So that is huge, huge progress. And our target for 2030 is to have 90% of people no longer requiring interventions. We are already in 32% of people no longer requiring interventions. There is diseases targeted for different things: eradication, elimination as a public health problem, control. So each of those targets vary disease by disease. As you can imagine, a diversity of 21 diseases, there is space for everything. And as Achim was telling us, the target for 2030 is 100 countries having reached at least elimination of one disease, and we are already at 57. And this is the map telling you all the countries that have reached at least one disease being eliminated or eliminated as a public health problem, and how this has happened across the line. Just to say that the NTD program is being very, very successful. The coverage of interventions from 2010 up to now is being very high for LF, for onco, for STH. Not that good for schistosomiasis, what is a drama, because we have this amazing donation we will hear later from Merck of the praziquantel, and unfortunately it's still being underutilized. The countries are not reaching enough coverage of children and women of childbearing age. But for oncocerciasis, for example, the coverage is being consistently very high. What are being the barriers for sustainability of the NTD programs? With COVID, all this wonderful high coverage that we were having dropped drastically with the COVID pandemic, and we have not been able to quite catch up 100%, although we have to say as well that some of the decrease represent as well countries no longer requiring interventions because they reach an elimination target. But nevertheless, there is still room to improve after the pandemic. This is one slide that probably you are not that familiar from the ones you hear before. Probably there is not much new information, but probably this one you didn't know. That in 2018, we had almost $600 million being invested every year from external funding, from governments and from private donors, for neglected tropical diseases. And this is without considering the cost of our most important donated pharmaceutical products. So all the medicines are not considered here. But if you only think in the US dollars being invested, we had almost 600 million. In 2023, it has dropped already to half. So the drop of the funding from USAID was by no means the first one dropping. Unfortunately, the UK disappeared before, and then it followed the US. So the three major donors were the US, the Gates Foundation, and the UK. And from those three, now there is only the Gates Foundation remaining. So clearly we are in real trouble. Luckily, we had some new players coming, like the Mohammed Ben Zayed Foundation for Humanity from the Emirates, and I don't know if anybody representing that is in the room, but they are being a really important new investor, and we are very thankful to that, investing in the space of neglected tropical diseases. So we are in a situation where all this funding that was coming from the USAID to support elimination of NTDs has been cancelled, and the countries have to rethink what they are doing because this money is no longer available. When we sent a survey to the WHO country offices to ask them what has been the disruptions after the closure of USAID, 88 of them highlighted neglected tropical diseases as being one of the key programs being damaged. Unfortunately, not the only one. As you can see, there is a competing long list of programs being disrupted. And of course, that is a problem because there are so many competing priorities at country level being disrupted. We created a dashboard, and here you have the QR code where you can consult it, that is publicly available to try to monitor the impact of these disruptions at country level and how many medicines were at risk of being expiring, how many millions of people were at risk of no longer receiving treatment due to the USAID cuts, and we update it as much as possible to be able to keep track of the interventions that are being at risk. We also tried to assess with countries where were the main barriers to achieve sustainability in NTD programs. And obviously, the low political prioritization at country level came at one important one, the dependence on external funding. The countries immediately were talking about going to another donor. They were not really trying to find domestic solutions. But there were a lot of work being done with the countries to try to raise the profile of NTDs and try to say, Unfortunately, there is not going to be other donors jumping. We need to find domestic solutions. We need to find opportunities to mainstream the delivery of NTD services within the health system through routine services and be able to continue these important life-saving treatments that we are receiving for free donated and not let them to waste and actually deliver them in the populations we serve. So what are the opportunities? The roadmap in 2020 already talked about how NTD interventions should be delivered through the health system and how we should move to a more country-owned sustainable approach. Unfortunately, at the time, it was not sufficiently implemented because maybe the money was there and countries were not really perceiving the need to integrate. Now, the reality has faced into us very dramatically, and the countries have not been sitting. They have stepped in and tried to identify solutions on how to deliver these programs without external funding. So we reached out country by country from WHO, working with the regional offices and trying to understand what are the countries doing to be able to deliver these programs in the absence of external funding. And we were very impressed by how countries are stepping in and trying to find creative solutions. We have examples like Ethiopia, where the campaigns for NTDs have been integrated with malaria, vitamin A, malnutrition, services for pregnant and lactating women. And here is where I say there is a lot of information that I cannot cover, but you have plenty of countries highlighting integration with, for example, Madagascar saving $1.4 million that were no needed because they were able to integrate with polio and in door-to-door treatments. And like that, you can see how many creative solutions the countries were able to identify. And now we are trying to work with countries on how this, instead of just an anecdotal one-time thing, can become a policy at country level, how this can be embedded in the Ministry of Finance, in the Ministry of Health, in the public routine service delivery of the health system, so that they can every year be sustainable and plan it in advance, rather than only a response to a crisis. Countries were very rich in trying to assess what make NTD programs sustainable and how we could mobilize domestic resources, how to improve the prioritization at country level, how to integrate communities, how to move from vertical to multisectoral approaches. And these are some of the elements that we are working with the countries to try to promote. And one of them is really the flexibility of the external funding, so that the countries can utilize the funding in a more flexible way and cover multiplicity of needs. How countries should have a plan with a budget that goes across the different diseases and how the external catalytic funding can support in a flexible manner. I'm going to pass these ones as well, maybe for later discussion on what was some of the lessons learned from integration and from mainstreaming into health systems. And this was another survey that we sent to all the NTD program managers in the world to try to understand what are the key enablers to achieve sustainability. And clearly the planning, the budgeting, the flexibility, the empowering, the advocacy came as very important topics on how we have to support them to have much more responsible decision-making at country level and less micromanaging from the donors and trying to allow the countries to make their own decisions and to use the way to deliver the treatments that make the most sense in their own country so that they can use innovation to deliver in a more integrated way across diseases. And embedding into the primary healthcare services was also an important topic that was raised. Anyway, we are now in 2025. We have 5 years ahead to the NTD roadmap, and we are in a midpoint. So the WHO is leading what we call the midterm review. The midterm review is going to be working with countries to assess where are we after 5 years of the NTD roadmap and how we can do things differently to achieve and accelerate towards the 2030 targets in a very constrained funding environment. This is the work we are doing to try to have a document that will be called the midterm review and to identify opportunities, challenges, and have specific recommendations for each country on how to move towards sustainability. And I'm going to finish, because I know the time is way past, with a meeting we had in the Rockefeller Foundation a couple of weeks ago the call from crisis to opportunity to try to discuss with global health leaders. This Rockefeller Foundation has been doing these meetings with high-level policymakers for a long time, and we try to identify what are the key messages to try to move towards more sustainable and country-led programs. And these are the key elements that came out of that meeting. Countries must lead with country ownership, prioritizing NTDs, and being really the leads of the NTD interventions. The NTD services have to be embedded into the health system and not be run in vertical ways, starting by the supply chain management of medicines. Everything has to be done through the health system. The communities and the people have to be at the center, and the interventions have to be distributed in an integrated way with malaria, with campaigns, with vitamin A, with vaccination, whatever makes the most sense for that particular community. Partners must switch to a more catalytic and enabling environment where they support the governments in their own agendas. And the financing must evolve, becoming smarter and more diversified, more sustainable, with the domestic investments at the center. So these are the key last elements. I hope this is not just one, let's meet and repeat the same thing, but actually change the way we work and move forward towards a more sustainable NTD delivery interventions. Thank you.
Maria, thank you very much for this setting the scene and the insight you gave us. We will discuss all presentations at the end, I would suggest. And therefore, we are going on now with already introduced by Maria, the company Merck. And I'm very happy to welcome Johannes Waltz. Here, he's not the first time with us. Johannes is head of the Merck Schistosomiasis Elimination Program and also director of strategy and finance at the Global Schistosomiasis Alliance. And he's responsible for the placement of 250 million tablets, not 1 billion like the pledge yesterday, but 250 million tablets of praziquantel throughout sub-Saharan Africa and beyond. And Johannes, the floor is yours. Thank you for coming.
Thank you very much. Thank you, Carsten. Thank you very much to both of you for inviting us here. Maria set the scene. Maria nearly said it all. I'm not sure what I can say beyond that, but let me try anyway. I'm from Merck, and let me get the, sorry, the wrong button. Let me get the corporate thing out of the way, just for you to know. And I have to stress it, I'm from Merck, the German. So not MSD, not the other Merck, which is a very young company because we are more than 350 years old, believe it or not. We are a multinational pharma company in 65 countries, and we are a sort of mid-large size multinational pharma company, which invests which has business in life science, in electronics. Yes, believe it or not, many of your liquid crystals in your mobile phones come from Merck, as well as in healthcare. And that's where Schisto, of course, is located. I'm in the corporate part, but the program, the Global Schisto Alliance on the one side, but particularly the donation program is very much a corporate sort of program. We are firmly committed to provide praziquantel until elimination has been achieved. That's no mean commitment. We've made this quite a while ago. Maria mentioned the London Declaration. Since that came out, the company committed to provide up to 250 million tablets of praziquantel, still the gold standard for the treatment of schisto, until elimination, and we have slightly differentiated this as a public health problem has been achieved. In the case of schisto, I'm afraid we are still quite a way away from that. Nevertheless, we are in the middle of combating this terrible neglected tropical disease, one of the big 5 PC, preventive chemotherapy NTDs. Still 250 million cases around. It's always underestimated. Who has heard of schisto? But so many people hear of malaria, which is where schisto is the second most devastating tropical disease in terms of impact right after malaria. But schisto is not really that well known. Africa, sub-Saharan Africa is the epicenter, if you call it like that, of schisto infections. And that's where the vast bulk of our treatment provision goes to. We have provided in total about 2 billion tablets, 2 billion treatments over the years, treating nearly 800 million patients, primarily school-aged children. But we are very well aware that school-aged children are certainly a main reservoir, but we also have preschool children as well as adults who need to be treated to get rid of this disease. Tablets is, of course, our sort of bread and butter, but we do more than that. And I'm really glad to say that we are looking at this as a sort of systemic, integrated approach when we involve ourselves, when we invest in getting rid of schisto. We are involved in FGS, the female genital schistosomiasis, male genital schistosomiasis evolving as we speak. We are investing partially in diagnostics. Diagnostics are hugely important, and RDT, rapid diagnostic test for schisto. But we're also looking at new treatment options. We have one compound under development currently because we all know the horror vision that resistance at some stage sets in. For praziquantel, we need to sort of also look at the future, how we can continue to treat. And then we have the additional interventions. We all know that schisto, as so many other NTDs, cannot be sort of combated by treatment alone. We have to have the additional interventions like WASH, like vector control. And we are particularly looking at health education leading to behavior change, which is crucial when trying to get rid of schisto. So it's an integrated, systemic sort of investment program, which we have in this context with praziquantel, the treatment at the center of our activities. Very important, and this is the situation which we face increasingly, donor fatigue in the case of neglected tropical diseases and otherwise is certainly a problem because we need to see progress. We've seen progress in quite a few, Maria mentioned it, of the other NTDs, but less so in schisto. And it gets very difficult to keep the momentum going at the top level with our massive investments in this NTD if we can't see progress. We have seen progress, however. The Swiss TPH, Swiss Tropical Health Institute, has recently, well, a couple of years ago, published an article in the Lancet Infectious Diseases, which clearly shows that preventive chemotherapy in the case of schisto has sort of resulted in reduction of prevalence levels, for both forms of schisto, hematobium and Mansoни, and that came as a little bit of a panacea, as a sort of manna from heaven, to show that our massive investments do have an impact, and that needs to continue. Impact it has, and the overall vision, the overall direction which we take in the case of schisto is elimination. I mentioned it, but before we reach to elimination, we have to continue to control the disease. We have a situation of 45 countries, which is certainly not coherent. In some countries, prevalence levels have reached to a sort of degree where elimination as a public health problem has either been achieved or is in sight, as well as sort of eventually reaching to interruption of transmission settings with sort of some hope that that will increase as we move towards the 2030 target of the roadmap of WHO. But these are our sort of targets, together with the variety of NTD stakeholders, the schisto stakeholders. Mind you, we are very happy that nowadays we can talk about elimination of schisto as a realistic target, because there were still stakeholders, and there are still stakeholders around who say, well, forget about elimination of schisto. It will sort itself out as we move along, but it's the eternal sort of control NTD. We are not of that opinion. We are in it for elimination. So here we go. As beginning of this year, the situation certainly hasn't become easier. Let me be frank about this. As we all were sort of thrown into the deep as of January onwards, we faced a situation for 2025 where a massive amount of tablets were at risk of expiry, totally unacceptable from our point of view, not only from the investment, but primarily from denying the children and the patients who need the treatment the possibility to actually receive it. So I'm glad to say 2025, we together with a variety of stakeholders, whether it's WHO, whether it's the End Fund, and maybe other stakeholders in the room, we managed to sort of avoid the worst impact, which was quite real at some stage, of the loss of tablets, of the loss of treatments made. That's 2025, and we are close to the end. But 2026, and I don't want to sort of hide it, is still a huge, huge challenge. We go on sort of assessing the situation on a constant basis. We still have countries where implementation funding, we are for the first mile, that's our sort of duty. The last mile implementation of the tablets which we provide is up to the countries as well as the multitude of stakeholders, NGOs, implementers, to bring it, so to say, down the last line, the last mile. So you can see the sort of risk assessment for the USAID countries, which dropped out, is one thing, but let's not kid ourselves. The situation before USAID was closed, which is a pivotal moment, of course, the situation before that wasn't exactly easy either. There were other donors, other sort of investors which stepped out, and the situation remains fluid. And we very much hope that we can tackle things as we go into 2026. The future of combating NTDs. Well, what does that mean? I think Maria mentioned it, the integration piece. Carol, you mentioned yesterday, it's a bit of, at the moment, an overused sort of term. But at the same time, I think it is the sort of short-term fix, if you call it like that, for the continuation, particularly of schisto treatment, the integration with other sort of NTDs, the integration with other sort of public health systems, public health interventions, as well as the integration into primary health care systems. This is the way forward. We have a very clear case, I can tell you, at the end of last year, before the January disaster set in, we had a situation where one country, Uganda, I think it's no shame to mention it, had 10 million tablets in stock at risk, high risk of expiry. A very quick sort of decision was taken, integrate with Child Immunization Day. And lo and behold, we managed together with a variety of stakeholders to get these 10 million tablets, means 4 million treatments, out and avoid the loss of that. Integrated MDAs with primary healthcare, I mentioned it, yes, also with WASH, of course, the One Health approach, and in the future with malaria. There are loads of opportunities where we can see this integrative sort of effort taking place. I don't need to go into the detail of the benefits, but let me tell you, it's not a straightforward thing. Maria will be in the best position to tell you that it's not a one-size-fits-all necessarily. There are different forms of integration. There are challenges with governance and coordination. There are challenges in the context of financing and data and monitoring systems, which are not, if you have a vaccine versus an NTD monitoring system, they need to come together. And of course, health care workers need to be trained. We are, in many cases, used to work in silos, but at the same time, integration is not new. It has been around for a long time, and many countries have done it for quite a while, whilst at the same time, other countries got used to different funding streams and different approaches to treatment. Now, integration, short-term fix, as well as mid and long-term, no question. early on was, as many of you, I think, or quite a few of you as well, we have to look at new, there was a session in the morning about the new financing architecture for global health, sort of organizations, multilateral organizations like Gavi Global Fund. Going one step further, or one step down, so to say, in our area, there are a number of innovative more or less, financing instruments which may or may not come to the fore in the context of NTDs and Schisto. The debt swaps for health are not exactly terribly difficult, where countries sort of restructure their debt and sort of commit to investing the restructured debt into NTD interventions. The development impact bonds, where a private financier sort of invests upfront, gets the money back potentially from governments and other investors when certain levels of or certain endpoints have been reached. The milestone-based funding for diagnostics, particularly, or in the R&D place. My colleague from our DNDi will have more to say about that, as well as pooled procurement of the NTD drugs, which are sort of instruments which have been looked at. I can refer you to a report by Glide, where a working group sort of looked at these various models and options. What are we doing in Merck about this? Because we may not take it for granted forever that the pharma contributions in the form of the medicines continue forever. We also have to become sustainable. We also have to look at some sort of transitioning into new approaches to providing these NTD medicines. And make no mistake, this is not an attempt to get out of it. It's just in the interest of the sustainable nature of these programs, the sort of desired sustainable nature of these programs, to also look at the long-term provision, the long-term feasibility of providing these drugs. So we are working with a number of countries which came to us and said, can we please purchase, can we procure drugs from you? And we are totally open to that, of course, whether it's countries, whether it's multilateral organizations, this will always be an option. And make no mistake, once again, this is not a for-profit product. Praziquantel, treating the poorest of the poor, will never be a for-profit product. If a cost price plus sort of approach is being taken, the plus will be reinvested in the NTD, will be reinvested in our case in Schisto. So our aim is to find these sustainable treatment packages across all age groups. Some of you may have heard that Merck is sort of also having a pediatric formulation, which will be sold at cost price. We package this together with the school-aged and adult treatment and look at these new sort of integrated packages on the one side. We have a number of new tools, including digitization, which are under development. And very important, we also want, together with partners, look at the sort of honing in on the patient who really need the praziquantel, who are really infected, because what we do at the moment with the approach of MDA is really treating probably far too many patients than needed. So increased efficiency and effectiveness of the product provided. Last but not least, at the center of all this, I'm being told I'm far over time, the all-important issue of partnership. This is the panacea. We need to work together right across the NTD field, right across the global health field. We need to look at these new opportunities. I like to think, and it's easy to say, the current threat is less a threat, but an opportunity to open new chapters, to open new partnerships, which we just have entered into a great partnership with the End Fund, to really look at these solutions to continue to combat NTDs. Thank you so much.
Thank you very much, Johannes, for your talk. And you took the freedom to incorporate the another speech that we originally planned, namely by the new Ghanaian ambassador who comes from the NTD field as a biotechnologist, actually, but he's not yet accredited, so he could not actually take part in these 5 minutes we gave to you, as it seems. But anyway, I think it's an important topic and we could discuss, of course, much longer. Our next speaker will be Laurent Fraisse. Laurent Fraisse is from Drugs for Neglected Disease Initiative, DNDi in Geneva, where he serves as R&D president. He has a PhD in biotechnology and was a long time active in pharma, in Sanofi and Evotec, where he held vice presidencies for infectious diseases. So he knows what pharma needs to do. And on the other hand, he's now in public service, so very well suited for PDP, a public-private partnership. Do you manage to get your... Okay. So the stage is yours. You switched on your talk, so looking forward to your talk.
Thank you, Achim. Thank you for the invitation at this forum. So my talk will be about R&D, and R&D is about innovation for the future. So you heard a lot about access and implementation, but we also need to think about the future treatments and the drugs that are needed to sort several health needs for neglected population in the field of neglected tropical disease. So my question was about what challenges does NTD research have to overcome? There are many challenges, and I think Maria somewhere answered to the 3 first bullets in terms of challenges. So rapidly changing global health environment, I would even say brutal change in 2025, as Maria highlighted in terms of funding. The overall decline in R&D funding has been also presented. And despite a couple of a very promising effort in prioritizing, as an example, visceral leishmaniasis in East African countries, we are still lacking prioritization in national health strategy of affected countries of NTDs. Another point is about the fact that R&D is inherently slow and risky. More development takes time, and it is difficult to handle a portfolio under those circumstances, but when funding is limited in volume and time, it's becoming very complicated. You imagine a portfolio of drugs to achieve one specific goal. Let's take the example of visceral leishmaniasis, where we have several drugs in development. It's much better to drive your choices by scientific data rather than funding opportunities. So when the funding is too much fragmented, it's becoming a challenge. That's why also, and the next challenge is, in our view, the lack of alignment and coordinated approaches amongst R&D funders. We see also an emerging issue, long-term, linked to the progresses made in artificial intelligence. Neglected diseases have neglected data sets. They are fragmented as well, in particular at the level of the patients. And we see here an increasing gap between therapeutic areas that benefit from those new technologies and the lack of data acquisition, the lack of data aggregation, management for neglected tropical disease. And the last challenge, I will try to illustrate it in the next slide. This is a transformation of the pharmaceutical innovation model. I just bring this information. This is about the number of DNDi partnerships with large pharmaceutical companies over the years on R&D projects. Again, my focus is really on R&D. And you see this very clear decrease in number of pharma that are interested in partnering with us on neglected tropical disease innovation. Well, the reason the reason are clear. There are 2 main drivers to this change. The first one is a decreased appetite for infectious disease abroad, and of course, neglected tropical disease being one of them and probably one of the most neglected. The second one is optimization of pharmaceutical R&D organization by externalizing some skills and expertise from the value chain, from early discovery, chemical manufacturing and control, safety, pharmacokinetics, phase 1, making actually a situation where most of the internal resources being focused on high priority programs and leaving much less space for what we benefited from the past, which is in-kind contribution from our private partners. It doesn't mean that we don't have champions, and I would like to highlight and thank them. Most of them are in the room, so we have a handful of committed pharma champions that are supporting our innovation effort. So it's not fully negative, and this commitment is strong and sustainable. So how can we try to overcome those challenges and bring medical innovation to neglected patients? So our first element is really to keep the patient needs. Patients are sick, they are sick from diseases at the center of R&D activity. Try to offer them affordable, accessible solutions that improve their quality of life. We need definitely, looking at the changing ecosystem, to develop new partnership and diversify this ecosystem. So we have more and more partnership with public and private pharmaceutical actors from the Global South. We see also emerging innovation product coming from the academic world, and that's something that is new and that we would like to support. And we would like also to strengthen the network of academic and scientists from the Global South in our partnerships. We need to continue to strengthen advocacy for NTDs, demonstrate each time it is possible the value of an investment for the future by demonstrating what R&D is able to achieve. And as I said before, thinking end-to-end in supporting the pharmaceutical R&D value chain is better than having fragmented support. So just trying to illustrate what success may look like for us. It's still not the end of the road, but if we take the example of sleeping sickness and the different generation of drugs that together with partner, our organization has been able to deliver, with starting from nifurtimox eflornithine, a combination of 2 drugs given by infusion, then a first regimen that is oral with fexinidazole, successively demonstrated active against the form of sleeping sickness with TB gambiense, and then more recently for the most acute form of the disease due to trypanosoma brucei rhodesiense. And a newcomer, we expect a newcomer, this drug has been submitted together with our partner Sanofi to the Medicine for All process of the European Medicine Agency a couple of weeks ago, and we expect to have feedback at the beginning of the next year. So success is not only R&D. Success is that during this time frame, 97% of the cases have been reduced. So the cases have been reduced by 97%. And this is due to those drugs plus a very successful vector control strategy for the tsetse fly. So this is possible by bringing partners together. This is possible because we think that there is an alternative R&D model that is possible, that is fully focusing on patient needs. And with that, I will stop here and thank also all the other partners and founders that are supporting our work. Thank you.
Thank you very much, Laurent, for your presentation. We do the discussion at the end, and I hand over to Carsten again.
Okay, then we are moving now from research to the civil society, and I'm very happy that Carol is with us by today. She's here for the End Fund. She's vice president of the programs in Kenya, and before that, she was chief of party of USAID funded integrated health project implemented by IntraHealth International in eastern Uganda. And therefore, she was project director for multiple HIV and AIDS, maternal child health, family planning, and human resources for health projects in Ghana, Kenya, Malawi, Mozambique, and South Sudan. So I think you're quite well experienced. And in your CV, you wrote that you like long distance running. So I think the field of NTDs is the right one for you, because there you need, it's quite a long distance. And you said you like to visiting new places. So we are in a new hotel here this time with the World Health Summit. So I think you are quite happy to be here. The floor is yours.
Thank you so much. And thank you everybody for coming. I assume this is it, right? Okay. All right. Okay. How do we go back? All right. So thank you everybody for coming. I think my job here is to bring everybody home. We've heard from Maria setting the scene, from what WHO has been able to do in setting us the guidance that we need. We've heard from Johannes, very important, the format donations that we get every year. We cannot do this work without these donations. Imagine if we had to look for drug at the same time, looking for money to deliver those drugs. And we've heard about R&D and the importance role that it plays in getting us to the money, getting us to more successful diagnostics as well as medicines. And the more successful that becomes, the shorter the runway to elimination. So to bring us home, I'll talk to you all about philanthropy. And I'll also talk a little bit about civil society, the NGOs in the room and all that. And how do we together work to sustain the successes and also accelerate elimination of neglected tropical diseases. I'll start by just giving us a quick background on the role of philanthropy. Because right now, as we see the issues that have occurred with USAID, everyone says, well, philanthropy will plug the gap. And in a way, I want to burst that bubble because, as you see here, the role of philanthropy is really to act as a catalyst, to act as a connector, and to act as an innovator. So they will not really fill that gap that you think they could because the money is not actually enough. So, but philanthropy does provide that catalytic funding that we all need for diseases like neglected tropical diseases, that is in a lot of ways not just challenging, but it's one that the investors see a lot of risk. But philanthropy comes in and plugs that gap for many of us. And then think about capacity strengthening. We need, for us to get to that integration that we are talking about, we need strong systems. We need human resource for health within the countries where we work. And we need that capacity to be able to then drive the change that we want to see in terms of system strengthening, not just within integration within health, but also within other cross sectors, such as education, WASH, and others. And then partnerships. I think all the speakers that have spoken today have talked about the value of partnership. We cannot do this alone. We all have to, I hope as we conclude today, we all make a lot of new partnerships because that's so important. Data and research and innovation, as well as advocacy and influence. This is really important right now as we think through how to pivot in this new era that we find ourselves in. But as we do all this, I say that philanthropy cannot replace government, it cannot replace civil society, it cannot replace communities, neither can it replace the private sector. So back to partnership, everybody has a role, and the more we begin to find each other so that we enhance those partnerships, the better it will be for us so that we can accelerate the elimination of NTDs by 2030. I wanted to then shift us to a realistic example. This is an example that the N Fund has set a partnership with one of the regional governments in Ethiopia, and specifically the Oromia Regional Health Bureau. Oromia region is one of the largest regions within Ethiopia. So, and the N Fund over the years, over I think 12 years, has been supporting, funding NTD programs in Ethiopia, including in this particular region. But in 2024, with the support of our board, we approached the regional president, actually, and said that we would love for us to work together in a place where we put in some money, they put in some, and we have a common goal that we all want to address. And so in 2024, we signed an MOU, a Memorandum of Understanding, between our two entities, the N Fund and then the Regional Bureau. And it was for $2 million. So it's a 50-50 co-financing, $1 million per party. And so this was already, we're in our second year now, so implemented by the regional bureau. So our job as the N Fund is to give $1 million, co-create together with the regional bureau, and they do the implementation. And this is just a few results that I wanted to share from 2024. And the one disease that I picked was the soil-transmitted helminths. I didn't put schisto here because schisto was co-delivered as well. But when we made our proposal, or rather when they made the proposal, it was co-created, they wanted to target 77 districts in the results. But being the regional bureau, they are able to have a holistic view of their disease burden, not just the disease burden that soil-transmitted helminths, but other NTDs. So with that, they actually expanded and delivered treatments in 233 districts. And as you can see, in the targeted, when we did the proposal, was about 2.5 million treatments to be delivered, but they delivered way over that. And the reason for that, again, is because they have that holistic view that any NGO in the room will not have. They know how to go wherever they need to go. They know when they're delivering maternal child health interventions or when they're delivering nutrition projects, so they can plug as they see fit. And then I put the trachoma surgeries here because I thought this was quite important. It was in this region where there is quite a bit of conflict, and as NGOs could not get there. And during the co-creation project, the co-creation period, I remember sitting across from the head of the regional bureau, and I was like, oh, there is conflict in that area. And he said to me, there's people in that area. We deliver primary healthcare. We will deliver trachoma surgeries. And so as you can see, they were able to get to the trachoma surgeries as were scheduled. And this was in addition to delivering WASH and NTD multisectoral coordination, behavior change work, as well as advocacy for schisto and STH. So what have we learned so far? We learned about the power of advocacy. I talked about our board, but as well as meeting the president. So it's more not just the health technocrats, it's about the politicians. And you need the politicians because they're the ones that have the money and they're the ones that will shape your health agenda. So then there is the patients. You need the patients to co-create and also have to trust the government partners know best during both the planning and the implementation. Like I said, I pushed back on the fact that they were going to a conflict area, and they pushed back, and I just let it be. But they were able to deliver. When they needed to go and do the integration, they didn't even come and check with us. They knew that they could go ahead and do the work at the end of the day. And then you have to have the commitment. We had to put in our money first, and then they put their money second. So we had to believe that they would put the money when they said that they would actually, actually put the money, because our budget years are very different. Our budget year is in January. The MDAs are in May, and their budget year starts in July. So we had to put our money first, have them start on the work, and then have them put their money as well. And then the other piece that we did learn is, like I said, 2024, 1-year agreement, because we were testing the waters. But we did learn if you do a multi-year agreement, especially with government, then because their own budgetary processes are set multi-year, 3 years, 5 years, then they have more advocacy power within their own systems to actually deliver on the targets that you set together. So we are right now thinking through what a multi-year agreement would look like. And then monitoring of the intervention is so important from the very beginning as you co-create through to the implementation and through to the end of it all. And even more important, monitoring of the expenditure. So how do we tell as the N Fund that they've put in the money? It's easier for us to say our money has gone, we've sent it, I can see the books, but how do I tell from their end that has happened as well? And so what next? This, I believe Maria and Johannes have spoken a lot about, but we have to pivot. We have to pivot beyond the donor-driven models, but instead invest in the partnerships that are rooted in trust, respect, and mutual accountability. We have to trust one another because that's the only way we're going to do this work. We have to listen more. Local expertise must shape, implement, monitor, and take responsibility for the results. So in the example that I just gave, that government takes responsibility for the delivery. We are not there pushing or asking, but we get our report every quarter, every 6 months, and it's really a one-pager saying we are on track with what we said we'll do. And if they need help, they know to reach out to us. And then the fragile context that we find ourselves in is also, to me, an opportunity. This is where we can leapfrog incremental change to boldly reshape a new era for public health financing. Thank you for listening.
Thank you so much. Carol, you are perfectly in time. We are quite perfect because now it's 12 o'clock and we have half an hour still to discuss. So the question is, what is the future of combating neglected tropical diseases? And you heard some suggestions by the presenter. Thank you very much again for your talks. And now the floor is open for your questions and maybe your advices and your ideas. So who would like to start? Okay, he was the quickest one. Colleague in the first row, and then we go second row, third row, and so on. So
Yes,
please,
thank you.
please, in the beginning, just introduce yourself very shortly that everyone knows who you are.
Hello.
And then
Fabian Gusowski from ASI. Maria, can I ask you a question about the restructuring of WHO? Very, very interesting. And I think it makes a lot of sense in terms of efficiency, breaking silos, etc. However, I think there still remains differences between malaria and NTDs in terms of how WHO will handle those in various activities. And I saw that, for example, NTDs access to drugs seems to be a different box that does not include malaria. What about other differences that may exist between NTDs and malaria and how WHO will be handling in the new structure?
Take several, or you want me to respond? Yeah. So just because we are merging doesn't mean we are disappearing as individual diseases. So the technical leadership of each of the diseases is actually being maintained. And there is going to be technical leads as well for areas of diseases. For example, I am the technical lead for all the preventive chemotherapy diseases for NTDs. And then there is a similar person doing that for malaria. So there is going to be, you don't have to worry about that because we are going to be able to maintain those differences. It's about working together and finding synergies. It's not about just melting and disappearing. So I think the structure allows for that, let's say.
so there are three more persons. The second row, I said we go one row thing, so we start with this lady over there.
Good morning. My name is Dr. Dattenberg Doyle. I run Right for Education, Africa's largest social media platform, which works in 45 countries with 300 people on the ground. I love your work, and if you can support it in terms of partnership, reaching them, discussing with them, listening to their problems, but also coordinating projects, we would love to do it. And I think we are very cheap because we are on social media, we reach them directly. The speed at which we work is phenomenal because we can target pregnant women, 3 months pregnant north of Kumasi, and we can get you a couple of hundred of them within a couple of hours. So if you want any of these services, we would be delighted. Thank you.
For sure.
Ursula Schäfer-Preuß, UN Women, German National Committee. I'm an economist. I have been in development cooperation for all my professional life and beyond. I wonder, integrated systems are really great, but how to get it organized on the ground, get the domestic health teams on board on the local basis. I think this is quite a challenge. And you need funds for that. You have to have the partners who are prepared to enter into these integrated systems. It's a good idea in theory, but how to put it into practice?
Maybe Carol, you would like to answer?
Yes. Let me see, how does this work? All right, I will do my best and anybody else can help answer this. And I speak this from my last job, actually. I was supporting integrated health systems in Uganda. And the first thing that I learned was I went into it thinking how difficult it was going to be. But it was one of the easiest things that I found, because the systems actually are there. There's a policy. There's the strategic health plans that are very clear, and all of them are actually very well integrated. They talk about integration and how the different services fit together, and think about the healthcare worker in that health facility. This healthcare worker is not just trained to give a jab for malaria. They are trained to do multiple things within that health facility. The issue, though, that has gotten us to these siloed systems is the funding, because then the funding comes in, and it comes in, this is HIV, prevention of mother-to-child transmission. Please do not touch HIV, something else. So you find that that whole health worker who could, in that primary healthcare facility, provide multiple services can only provide one now. So I think we have to go back to the drawing board, go back to those documents that are already there. I don't believe we have to tell the ministry or develop a health strategic plan, because the health strategic plan is there, and it is an integrated plan on how to take care of its people. So I think it's more the will of, can we first look at what's there before we say, okay, it's not there and it's going to be difficult. And I must say, in that example, I remember the district health officers were so happy because they had the support, in this case, of USAID was like, go in there and work with them within their system. And all they would say is, we've always wanted to do this. I remember there was something that they called quarterly performance review, basically bringing all their units together to review what they've achieved for that quarter. But they never did it simply because they didn't have the money. And so our job was to plug. You have that for one quarter. And then the question would be, who pays for the next one? And then I'll say, that would be you in your budget. And then we'll pay for the next one. So it became like a partnership. So like I said, it was much easier than I thought, because I thought it was going to be so difficult creating the system, but the systems are already there. So I believe the systems are there.
Thank you. So now the gentleman next to you. Yeah.
Hi, Matt. My name is David Cox. I'm a global health journalist for Wired. I had a couple of questions. The first one was, Maria, you mentioned how there's been lots of an issue of like donors lots of kind of exiting over the last kind of like 5 years. What would you say is the best example of an NTD which has been particularly affected by, or been most affected by, like so that lack of donor funding and the drop in funding? And secondly, like so someone else also kind of mentioned there's a bit of an issue in the NTDs in terms of like a lack of good data. And I just wondered, what is the main reason for why that's the case?
Yeah, so the diseases that are being the most affected, well, if you think on the UK and the US, they were mainly investing in the preventive chemotherapy diseases. So the LF, onco, cysto, STH, they were investing quite a lot in trachoma as well. So those ones are obviously being affected. Luckily, we have the Mohammed Ben Zayed Foundation for Humanity with the Reaching the Last Mile Fund coming to step in for LF and onco. I don't think there is a similar one for cysto and STH. So those ones are clearly being affected, as well as human African trypanosomiasis and leishmaniasis. And the question about data is because I think many times the donors, including philanthropists, they are interested in delivering treatments, and they were not always interested in the impact. I think now the mindset is shifting, and they are trying to think that impact is actually hugely important to measure, and that we need to invest in data. And we saw that during the COVID pandemic, how real-time data and information was so important to understand what we were doing. So I think now there is that shift, but of course, the impact assessments cost a lot of money. Doing field assessments and data generation cost money, but it's a hugely important element when you want to reach elimination. So hopefully we see that shift as well. And I think in the WHO side, we have to facilitate the job of the governments by trying to make the impact assessments and the evaluations more manageable across diseases, because sometimes we have created impact evaluations that were so specific for each disease. Like if you do it for human African trypanosomiasis, it has to be this way, and if it's for cyst, it's this way, and if it's for LF, it's this way. That made the work of the countries impossible, why surveillance should be much more easy. You can do surveillance with blood in many multiple ways with no matter which sample you get. So we have to simplify as well to be able to achieve integration in a much more easy way through the health system.
Laurent.
Just one element, is it working, about the data as well. So I was also referring to scientific data that are collected during clinical trials, as an example. It's very often now that for many therapeutic areas like immuno-oncology or diabetes, that we collect a lot of transcriptomic information about the patient. We get a lot of information about the patient status and how the patient reacts to the disease. I've heard about digital twins, meaning creating almost digital patients aside of the real patient in immuno-oncology. I would love to have digital twins on Chagas disease because we don't know why some people are developing the disease, having cardiac effect, whereas it's only 30%. How are the next, who are the 70% one that do not develop the disease? So there are many elements that I think the modern use of data acquisition in science will create a lot of opportunity on many therapeutic domains. I am not sure this will decrease the gap with neglected tropical disease research.
Thank you. First, we go now to the third row. To the lady in blue, please.
Thank you so much. I'm just going to stand so that you can see me. Hi, my name is Manshri. I'm representing International Pharmaceutical Student Federations, and I'm the current president. So first of all, I would like to say that I was very impressed with the picture from WHO where you were presenting at Rockefeller in Bellagio, that on the left side, they were all white male presenting, but on the right side, they were finally working for our people, by our people, and I'm glad that this is happening in the global health sector for now. However, I would like to ask one question regarding NTDs today, as we are planning in the future to combat it. We know that there are 20 diseases, and not all of them were mentioned in this room today within a 1 hour and 30 minutes time. What are your plans to ensure that all NTDs are being covered? Like, for example, snake bites have a different approach in treatment and also way forward with how we integrate it with the community. So if you could suggest steps that have been planned or any resources planned from your side that can be shared among our attendants so that we can also probably creating our plan to work with you in the future or maybe collaborate with the others in the room. Thank you.
Thank you for this interesting question. So, Laurent, Maria, would you like to answer? 21 different diseases?
So 21 different diseases, of course, it is a challenge because they are all different, okay? And this makes also one of the specificity of NTDs versus malaria as an example where you deal with 1 or 2 pathogens only. So I cannot talk about all the disease, but I can just tell you at least at R&D level, our organization is working on sleeping sickness, Chagas disease, visceral and cutaneous leishmaniasis, mycetoma, very neglected disease, a fungal disease, the fungal form particularly severe of the disease, dengue, pandemic preparedness, and we have a supportive activity as well on snake bite. And last but not least, a big investment in I would say helminthiasis as a broad, so meaning filariasis and schistosomiasis as well. So again, it's not 21, but it's still a significant effort at R&D level. And happy to dialogue on opportunities. Thanks.
Maria, do you would like to add something or it's fine?
Well, unfortunately, just to say that some of the diseases that are in the package of NTDs were added exactly because they are neglected to give them more visibility. That has not necessarily always resulted in millions flowing for it, but that's why we are pushing and we keep the advocacy. But you are absolutely right. There are some diseases that still do not have enough attention. All of them don't have enough attention, but some of them have zero attention. And I mean, just compare even malaria and NTDs, how many people work in malaria just in WHO compared with in NTDs? I mean, it's just embarrassing.
Yeah, thank you very much. It's a very wide field. More questions, please. So we just go backwards. There are two gentlemen. Please. Also,
hello, I'm Olivier, from expert on clinical trials. Maybe a question for Maria. Mucho gusto. How do you manage the NTDs in conflict zone, such as East Congo and this area?
In the complex settings, you
Yes.
mean? Well, we are working with the governments, and obviously WHO has presence in every single country in the world, particularly in Africa, and the WRs and the WHO country offices really work hand by hand with the ministries of health. That's why we say the WHO has the 3 levels of the organization, not from the headquarters to the regional office to the country level. So it's not that from HQ we are trying to be implementing. So through the WHO country offices, where you can really work with the governments and try to work in no matter which complex settings, like South Sudan or countries that have really very complex situations, to be able to deliver interventions in those type of complex settings. Because luckily there is, as Carol was reminding us, communities live everywhere, and primary healthcare and emergencies, they have to be always deliberate, no matter in which situation. And it's through that deep knowledge of the health system that you can work when you are there in the base.
Something? Yeah. So I'll speak about NFund funding right now. We work in about 32 countries, and of those, about 10 of them are countries that are in one way or the other impacted by conflict. And the idea is, who are you working through? If you're working through the government, then the government is really able to either identify for you a partner who they know that can reach those particular areas, or they can get the money themselves and do the delivery. So the idea is, you don't neglect those areas because they have conflict, but do your best to see how far, working with the systems at hand, you can input resources to get work done. I'm happy to speak to you a little bit more after.
Okay, there was a question by this gentleman, and then in the back.
Yeah, thank you very much for that all nice presentation. I'm a professor for surgery, specialized on oncological surgery and lymphedema surgery. I would like to ask one question about the future step, because as you know, I heard some about a long distance runner, the future of combating, and what do you have? Do you have any special program for the future warrior? I mean, we have a really interesting student. We have an exchange program with Uganda University of Mulago, but the financial from German side is already stopped, and we try to get some Erasmus program. And do you have any idea from German network for supporting such future lymphedema warrior in Uganda, and especially students from Germany who want to inform and help these people? Thank you very much.
Well, it's not an easy one. I think with some philanthropies, this is probably the best way forward, but you have to go from door to door, basically. So we have this situation as well that I'm asked similar questions. For individual students, indeed, it is a little more difficult when they don't come with a university partnership or anything like this. That's maybe really some lack of funding that you're speaking about, that we may take further and think what we can do about this on the national level, because a lot of that is bilateral. So, for example, if there is a bilateral program between one university and an African university, then this is usually possible. But this is very much fragmented indeed. There was a question here by the lady and waving her hand.
Thank you, everyone, for that very interesting presentation. I'm Neyman Sal. I work for the research project Target Malaria, which developed genetic technologies against malaria. My question is for Laurent, maybe Maria and Mr. Johannes, I think. Yesterday, I attended this very interesting session on the WHO strategy for traditional medicine. And I would like to ask how can we make space for, this kind of medicine that has tremendous and underexploited potential, and while still, respecting the ownerships of the communities who are already using it. So it's a very transversal question that maybe, Laurent and maybe Mr. Johannes from Pharma can answer. Thank you very much.
Yeah, thank you. I will maybe start. So it's a very important question. And so traditional medicine are probably traditionally used. And so we need to understand what is needed to eventually change this status quo. Is there a need to develop bigger data set, see if we can demonstrate by, I would say, modern clinical activity a benefit or not? But again, it's a very important point to acknowledge that there are some traditional medicines that are used, and there are also traditional compounds that are used for which there are lacking data sets. And the question is always, do we need to do something, or do we need to keep the status quo? Entering into, I would say, modern designs in order to demonstrate efficacy is costly and may not necessarily help the status quo for those medicines. So it's a very complicated question. But as a scientist, there is a basic answer that we cannot say no to this. We need to dialogue and enter into discussion and see, eventually advise as well, if there is some things to be done or not. That's my immediate answer. And maybe Maria, you want to say anything else?
I think
it's on. I mean, it's difficult for me to follow Laurent in this context. I think in general terms, of course, we have to listen to the communities where NTDs are prevalent. Of course, we have to see what sort of particularly preventative options are around. That's the education behavior change. In terms of actual medicines or actual approaches, in the case what we deal with, schisto, I think we have to be open to that as well. I mean, there are artemisinin focused or mixed approaches of new drugs based on artemisinin, etc. But it's difficult to frame that. I'm not a scientist myself, but one thing in very general terms I can say, we have to listen to the communities where the diseases are prevalent. We have to work with them much more and be sure that whatever we do is finding the right impact on their fronts.
Maybe I can just add a comment, because I've seen that also in the field, for example, with lymphedema work, that there is quite a lot of traditional medicines available that are antiseptic, for example, for ulcers due to lymphedema, and that's fine if that's being done and treated and patients are better. If you want now to bring such a compound in a plant, right, into a drug development project, I mean, Laurent can better answer this than I, and I've learned from the partnership I have with DNDi that you very quickly have to answer a few critical questions. One is, can the substance be isolated? Can it be scaled? Is it toxic? And if it is toxic, this has to be very quickly answered in a very general way, because a lot of substances then are dead if they are too toxic or if they are not scalable out of the system. I hope I don't say anything wrong here.
Sometimes,
there's a lot of, for scientists, very often disappointment. They have principle that is working, something very good, but then you realize, oh, I can never scale it to the kilogram scale I need for a drug development toxicity, for example. Anyway, so
maybe,
you have a
question. I also have a question for Johannes. You just had no 20 minutes relaxing time, so no tough question list I will put on the table. Because we have an interesting situation at the moment. It's concerning schistosomiasis, and it's treated with praziquantel. But praziquantel is no better available in Africa than here in Germany. In Germany, it's at the moment not available at all. So to treat patients, and all the medics among us who are doing practical work know that it's really hard to get praziquantel here to treat patients in Germany. So, Johannes, what will be the solution for the future? And is the drug availability for the other people in the world also sustained for the next decade?
Thank you, Carsten. The question was unavoidable. I'm aware of that. Let me try to answer it. Number one, the praziquantel which we provide is coming from Mexico. That's where it is produced. That's where it is packaged in bottles of 1,000 tablets, which don't lend themselves, number one, from the presentation point of view, but also from the registration point of view for use in other sort of areas of the world other than in sub-Saharan Africa, donated via the WHO track. We do have a presentation available in Mexico, where 25 tablets are packaged in much smaller bottles, obviously, which, however, cannot be exported into, say, the European Union straight away and overnight. Let's not forget that the regulatory situation across the EU varies a great deal. So we have a case in Spain where the Mexican product was imported with relatively sort of ease, whereas in Germany, it is much more complicated. So we are, however, not stealing ourselves, together with colleagues who sit in the back from another company, out of this sort of responsibility. We are aware of it. We are working on it. We are trying to work with regulatory agencies. We are trying to look at new presentations. We will have a new formulation of praziquantel coming out in about a year's time or so, which is an improved, taste-improved formulation, where we are also currently looking to have it in different packaging forms, which may or may not, depending on the willingness of European regulatory agencies to come into the EU. So we are aware of it, we are working on it, and we are really hoping that we find mutually agreeable solutions.
And maybe regulators are also watching us online or so, and we know we can sing a song of over-regulation in the European Union and also in Germany, so maybe we can do something on this one. So thank you very much, Johannes, and sorry for the tough question.
There are two more questions now in the first row, please.
4 minutes left, Achim, we have to be just in time.
Short question, short answer, please.
Good morning. I'll be brief. I'm Marianne from the International Society for Neglected Tropical Diseases. My question is for all the panelists, but it picks up on something you reminded us of, Carol. You basically told us that the healthcare provider is essentially the de facto integrated entity, and it was the funders that introduced silos. I'm assuming that's because it was maybe not the best way forward, but the easiest, perhaps, or the simplest. And so many of us not being financiers, is there any advice or anything we should think about in terms of already aligning our language or our optics to future funders to make that integration case more exciting?
Yeah, thank you, Mariam, for the question. And I know time is running. But when I think about integration, for me, even before I go to the health worker, I think about that particular person in the community who, I like to use the example of a pregnant woman. She's pregnant, she could get malaria, she could have HIV, she could be malnourished and need nutrition services, or she may not have all those things, but will need her antenatal visit, will need to get malaria prophylaxis in addition to all the maternal child health services that she gets to ensure that she delivers a healthy baby. So when you think about the human And the fact that they live in a community that has the different vectors that cause neglected tropical diseases, at the same time, she will get pregnant. At the same time, that kid will go to school. So when you think about the human, it becomes easier, at least in my mind, to then think, how do you deliver the services to this person within that community? And I refer to government policies and the strategic frameworks. They're actually written that way. They're written in thinking about the holistic human being in that community. When you think about the different tiers of the health system, that's how it starts. That's why that nurse at that lower level, the primary healthcare, they are everything they can do because they are dealing. And then as you go up, it becomes more specialized because then at that point, you're dealing with very special cases. So I think the whole idea is we need just to go back to the drawing board, see what's already there. And how do we work with what's there so that, and then think about the human who has to come 10 times to receive a service that she could have actually received in one setting because somebody else thinks, okay, I need this data and I need them this way to get to someone else somewhere. Yeah, so I think it's just thinking about the human and then the rest will follow.
Thank you very much, Carol. I'm very sorry for Mark van Passel and the others that we have to come to its end. There's only 30 seconds left. Achim, and maybe you want to say some closing words.
Okay, then we have to keep this question for some bilateral after talks, which you are invited to come to the front and pose your questions. I thank the speakers very much for the presentations again, and also the audience for putting up a lot of interesting and important questions that were missed in the first round. So I think there's a lot of work remains to be done. And if you take back the message that we are halfway at WHO's roadmap to 2030, but still 2030 will not mark the end of NTDs. I think that nobody has ever said this. We will need the joy in long distance running, as Carsten has said, to really continue, and hope that we will be able to convince all funders. I think it was an important point that came maybe a bit too short, to align. Drug development is a very long-term thing. And we in Germany have the German Center for Infectious Diseases that has addressed this question, at least with the money available. But there need be many more funders to have a more long-term perspective. GHIT in Japan, for example, seems to be another one. But there can be more aligning with the long-term needs of drug development and also of elimination of diseases. Thank you very much, and enjoy the rest of the World Health Summit. Thank you.
Thanks for coming. Bye-bye.